Hello. We are going to be discussing more alterations of pulmonary function. And in this lecture, we're going to go over pneumonia, acute respiratory distress syndrome, tuberculosis, cystic fibrosis, and I think that about covers it. But these are some complex topics, so let's get right into it. So, pneumonia, which is something that I bet all of you have heard of, is an infection of the lungs and it inflames the lower respiratory tract of the lungs. And it is yet another alteration that affects the alveoli. And in this infection, the alveoli alveoli fill with pus or fluid. Now, this can be due to a variety of pathogens. One that we're most common with is probably bacterial pneumonia, but also viruses, fungi, protozoa, parasites, they can all cause pneumonia. So pathogens can be community acquired, hospital acquired, or they can be very much related to immunocompromised patients. So somebody who is immunocompromised, they are vulnerable to any pneumonia, really, any pathogen, but also they're more likely to have pneumonia from things like fungi, cytomegalovirus, which I believe is um, that pathogen that lurks in litter boxes that they always tell pregnant women. That's why you shouldn't be changing the kitty litter. Influenza and toxoplasmosis. Um, and now I think about it, toxoplasmosis might be the kitty litter one. But anyway, I'm not testing you on the kitty litter germ. But know that there are some things that immunocompromised people are more likely to get. So let's talk a little bit about how these pathogens get all the way into the lung. Um, Generally, somebody aspirates, which means like inhales or chokes on an oropharyngeal secretion, or they inhale a microorganism from somebody who has an infection and that person sneezes or coughs or they're just talking. And there's also such a thing as aerosolized droplets, and the pathogens travel to the lungs. And this is kind of like a little drawing of what it looks like. Now, when things are going well and someone is healthy, remember we have in our upper airway something called a mucociliary escalator that traps and removes microbes. We also have those alveolar macrophages that are patrolling around the alveoli and they kill, most pathogens that are getting in. And then remember, we have surfactant that keeps alveoli open and supports immune defense. But when these defenses are a little down, or maybe there's just so many of the microorganisms that it kind of overwhelms the system, um, those microorganisms get inhaled, they're aspirated, um, or they come in those aerosolized droplets and they overwhelm those defenses, or sometimes those defenses fail. So, you can think of people who seem to get respiratory illness more often, and probably some certain categories of people are coming to your mind. So, people who are smoking a lot, um, they're a lot more prone to get pneumonia because they don't have those cilia to sweep the microbes out. You could have an impaired cough, and that could be because of sedation, like from medication you take, or it could be with age because you just don't have the muscular strength to have a really good cough. And then once again, immunosuppression or chronic illness can affect that. Um, so kind of the path, though, of what happens with pneumonia is that pathogen comes in and the alveolar macrophages detect it and release cytokines. Um, then that attracts neutrophils and other immune cells. And then there's this big old vascular response where the capillaries and the alveoli get really leaky, and that allows plasma proteins and fluid to enter the alveolar space. And then what we call exudate, which is fluid, neutrophils, debris, and that just fills the alveoli. Um, when there's enough of that exudate, that becomes what we call a consolidation, and that will show up, as white on an X-ray. That's what they see. Um, so this all is going to impair gas exchange in the alveoli because if the alveoli are full of all this exudate, like basically this gunk, it's going to make it very hard for that CO2 and O2 exchange to happen. And so that all leads to a lot of the clinical manifestations that we'll talk about in a bit, but definitely leads to breathing problems. So we have typical and atypical pathogens. Um, Typical pathogens, they're called typical because they respond in a pretty predictable way. Uh, Meaning, first of all, you can give beta-lactam antibiotics for them, which are generally your penicillin type of antibiotics. These kind of pathogens can be seen on cultured media and a gram stain. And so some examples of typical pathogens would be Streptococcus pneumoniae and Haemophilus influenza, which, by the way, that is not the same as the flu. Haemophilus influenza is a whole different thing. But so those are typical pathogens. They're fairly like straightforward to treat. Um, they're a little more common. And then we have atypical pathogens, and they're atypical because they don't behave in expected ways. They don't have a cell wall, and they don't stain or culture well. So you can kind of see that there on the right, how that looks totally different. They do not respond to beta-lactam antibiotics. So you could give someone amoxicillin all day and it's not going to do anything. Um, so some examples of that would be like Mycoplasma pneumoniae, Chlamydia pneumoniae, Legionella. So those microorganisms, it requires different types of antibiotics. And, sadly, they tend to have more side effects with them, but that's kind of a whole different topic. So here is something called ventilator-acquired pneumonia. Um, and this is a hospital-acquired pneumonia, and this is something that you as a nurse can help prevent. But basically, what ventilator-acquired pneumonia is, well, let me explain first what a ventilator is, because maybe some of you don't know. When people can't breathe for themselves, they will have what's called an endotracheal tube put in their airway, and it delivers breaths for them, and it delivers oxygen, and it provides full respiratory support. When people, I hate to be crass, but when people talk about pulling the plug, that's generally what they're talking about. Like, ventilator support means like a machine is doing all the work of breathing for you. So as you can imagine, this is quite invasive, that you have this endotracheal tube that's extending down into the bronchi. And what happens is that endotracheal tube becomes colonized with bacteria. So all this bacteria comes in, what's called a biofilm forms. And what a biofilm is a collection of bacteria that they just get together and they form this very dense film. It's pretty impenetrable to antibiotics, so you can see that that causes quite a problem. And then from there, we say the lung becomes quote unquote seeded with microorganisms, seeded. So all these little microorganisms just get dropped off in the lungs. And as you might imagine, somebody who is on ventilator support, they're already not playing with a full deck of cards, health wise. So if you think about those factors I kind of talked about with the lungs defense mechanisms, they really don't have those going on. So for one, when you're on a ventilator, under anal you're under sedation and analgesia. So that paralyzes the respiratory tract, and you don't have that coughing defense. And then also you don't have the mucociliary elevator working to get those pathogens out. So, um, a little more detail. Here's a little refresher again on the role of defense mechanisms. And, um, you know, so viral infections, smoking, pollutants, or endotracheal tubes can damage the cilia, and that makes mucus clearance fail. Like I said, the cough reflex is suppressed by sedation. As far as alveolar macrophages go, some bacteria actually just structurally have capsules to where phagocytosis doesn't work on them. So they can't be eaten. That's what happens in phagocytosis. They can't just easily be eaten up. So there's a lot of things that really work against, once these things are impaired, it's very easy to get pneumonia. So, what do the clinical manifestations look like? Well, most pneumonia is preceded by an upper respiratory infection. So it could be something that starts off like pretty confined to like the sinuses and the nose and a little cough. But say you're one of those people that you have impaired immune defense, or you're a smoker and you don't have like cilia doing their job, then that can move down into those alveoli and become pneumonia. So you're going to see fever is really common. Doesn't always have to be a really high fever either. Chills, it could be a productive cough. Generally, bacterial pneumonia produces a productive cough. Dry cough is more typical with viral pneumonia. And people will have malaise and pleural pain. So pleura, I mean the lungs. So plural always has to do with the lungs. Um, on assessment, we have pulmonary consolidation, like I said. And what that sounds like when you listen to somebody's chest with your stethoscope are crackles in the lungs. And then we have that word egophony that maybe you haven't heard of. This is pretty interesting. So, say I had pneumonia and I have some pulmonary consolidation in my lower right lobe. What you would do is you would put your stethoscope over, my lung field, that lung field, and if you ask me to say E while you auscultate, it's actually going to sound like I'm making a very prolonged A sound. And that is because of how that pulmonary consolidation causes sound to be transmitted. So, this is a very interesting like assessment test, because there are some areas where you don't have chest x-rays like readily available, but it's a good thing that can be done in assessments. It kind of gives a very strong clue as to the presence of pneumonia. You'll also see tachypnea, so fast breathing, like over 22 breaths a minute, and tachycardia, so a pulse greater than 100. How this is diagnosed. Now, you you don't necessarily need to have a chest x-ray like outpatient. to diagnose pneumonia. A lot of times, like a good provider can just kind of find it based on clinical findings such as fever, crackle in your lungs, but a chest x-ray will show the affected lobe or lobes. A CBC will be elevated, and a CRP would also be elevated. Bronchoscopies and sputum studies, these are really done if they're not sure um, they know what the pathogen is. So it's pretty important that people get the right antibiotics for what they have. So those come in handy as far as that goes, because we don't want to be contributing to antibiotic resistance. Here is just a picture of an x-ray with some consolidation. So white always indicates bone, or it could indicate some infiltrates in consolidation. Here's just a little side by side. I don't expect you to memorize it, but it's kind of interesting, typical versus atypical. You can see that atypical pneumonia usually comes on more slowly than a typical pneumonia. This could be your person who's just been kicking around with like an upper respiratory infection that just won't leave them alone for several weeks, and then all of a sudden they're running a fever. Well, very likely they have an atypical pneumonia. So how do we treat? So empiric antibiotics, and empiric means that basically the provider makes a very educated guess on, it being community acquired pneumonia. There are certain questions that they'll ask to make sure that they don't have a risk factor that would make it an atypical pneumonia. And then they prescribe an antibiotic that is going to cover a lot of different pathogens until they know what the pathogen is that's causing it. Um, with viral pneumonia, generally you just do supportive therapy. Pneumonia can be like quite dangerous, so sometimes like pneumonia can range from somebody just who's fairly young and healthy, just being like mildly inconvenienced with, a flu-like um, respiratory illness for a day or two that they take oral antibiotics for. It can range from that to somebody who is in the ICU on a ventilator fighting for their life. So there's a very broad range. Um, Supportive therapy just means like treating the symptoms. So viral pneumonia, any kind of virus will generally run its course. So somebody could need perhaps oxygen support if it was severe enough. Um, Sometimes if it's really severe with viral pneumonia, they will give antiviral medications. Prevention, so smoking cessation is huge, as well as getting pneumonia vaccines. I believe people who are over 55, maybe it's a little older than that, they all need their pneumonia vaccines, as well as people with HIV, because HIV is an immunocompromised state. Those folks are very susceptible to some of the really, really atypical pneumonias that are much harder to treat. So, especially important for those groups to be getting pneumonia vaccines. Um, Very important to keep your patients propped up a little bit. How you're positioning them, turning them, keeping them mobile, that's all going to help move secretions out of their lungs and keep pneumonia from developing. Oh, and also getting the flu shot, because um, pneumonia can develop from the flu, as odd as it sounds, because the flu is a virus that you could get a bacterial pneumonia from that, but you can. So, always good with those vulnerable populations for them to get their vaccines. Okay. So let's talk about tuberculosis. This is an infectious disease that is caused by Mycobacterium tuberculosis, and that usually affects the lungs. It can affect other parts of the body, but we're not going to talk about that in this lecture. So TB used to be quite common in the United States. Um, Up until, basically antibiotics were invented. But it was a really common like killer worldwide. It still is common in a lot of countries that are not the United States. Um, but, we've gotten so on top of TB monitoring that it's not super common that people are suffering with tuberculosis, at least not compared to how it was 100 years ago. So the initial infection is Mycobacterium tuberculosis, gets inhaled in a tiny little droplet, and then it travels to the terminal bronchioles and alveoli, and then those bacilli are taken up by alveolar macrophages, but they're not really able to be destroyed or destroy that well because they have a very waxy, lipid-rich cell wall. Um, that at that point, macrophages try to kill the Mycobacterium tuberculosis, but they're not really able to. So the bacteria go on to reproduce slowly inside of the macrophages, actually. Um, and then the infected macrophages show the Mycobacterium tuberculosis antigens to T cells, which triggers cell-mediated immunity. So then what happens is that a granuloma forms, and that is called a Ghon focus, Ghon. So after about 2 to 8 weeks, T lymphocytes release cytokines and activate macrophages to kill some bacilli. Those macrophages and lymphocytes will then go ahead and wall off the infection and form a granuloma. Um, so that is what they can see on a chest x-ray if you've been exposed to tuberculosis. So with the primary complex, the initial lung lesion, the Ghon focus, forms in the mid to lower lung zones. Um, let's see. So basically, that is somebody who got exposed to TB. That is not necessarily synonymous with having the active disease. So let's talk about latent TB a little bit. Um, that happens when bacilli are isolated after they lodge in the lung, and then a tubercle is formed. And like I said, the bacterium can stay alive within and just go on doing its thing. But when it is latent, it is dormant and it's non-infectious. However, if you have one of these, it's always going to trigger a positive PPD test. So make that known up front before you have to do any kind of testing. Um, with active TB, this is what happens when the immune system is impaired and that reactivates the progressive disease. And at that point, a person is contagious. So, what can happen is that somebody can fall under another physical stressor, such as renal disease, cancer, HIV, can all reactivate that TB, and then somebody starts coughing it up, and then it's extremely contagious. So, some clinical manifestations of TB, um, coughing that lasts 3 or more weeks. And I had been around people with TB before, and they just had this really persistent, in their case, dry cough. chest pain or pain with coughing or breathing, loss of appetite, chills. This is all probably seeming very familiar to you from when you filled out your papers for clinical compliance. So, or every time you get a TB test, they ask you this little questionnaire. So, fever and night sweats are a big one, but any collection of this should kind of give you pause. And especially if you look at the socioeconomic factors of your patients, if they are living in areas where they're having to live around a bunch of other people, then it's more likely these things could be tuberculosis. So, how do we diagnose this? Well, that lovely little PPD test that screens for exposure to TB. So, if you ever have a positive one, don't freak out because that doesn't necessarily mean that you have the active disease. Um, the quantiferon gold test also screens for exposure to TB, so neither of those tests can tell you if you have active TB for sure. The only way you can do that is a chest x-ray and sputum cultures. So um, those will be very good clues as to what you are dealing with. So the treatment of tuberculosis is for one, TB is an airborne disease, and it's important. This is your patient you really have to wear your N95 mask with. And it's important that they stay in isolation until they have a negative sputum culture. Because the sputum culture and the chest x-ray are really like the confirmation if your patients um, if they I'm so sorry, I lost my train of thought for a second. So sputum culture is really the gold standard test for if your patient has active disease or not. So it's really important that that patient stay in respiratory isolation. They will be in a room, hopefully a negative pressure room. I don't know if any of you have been in one, but it has the little antechamber that is like this whole other room before you go into the room. It's negative pressure, so air is basically getting sucked into the room. It's not going out. It's not exposing other people. So they have to be in that kind of isolation until their sputum culture is negative. They will be on combination antibiotic therapy. Now, they can't be on just one pill because what we don't want to happen is that is how resistance forms. So it would be really bad to contribute to antibiotic resistance when it comes to tuberculosis. So that's why a patient has to take multiple antibiotics for the TB. It is a mandatory treatment and it's enforced by law. So you can't refuse your TB medications. Um, Cases I've heard of where the patient tried to refuse a TB medication, a sheriff actually escorted the nurse out to the house. And, you have to take the treatment because you are such a severe danger to others. Um, it is really a public health accomplishment that not only the medications we give, but our good monitoring and surveillance of people who are working with high risk populations or in a high risk population. All these things drive uh, relatively low numbers of TB compared to what they used to be. Here's a little side by side of latent versus active TB. And as you can see, with latent, basically they describe those TB germs as sleeping, but they could wake up in the future. And at the latent phase, somebody has no symptoms. They have a normal chest x-ray. They are not contagious. but they would test positive on a TB skin test or blood test. And with active TB, we say that the TB germs have now woken up. And what causes them to wake up is a serious illness or being immunocompromised. And at that point, somebody would have symptoms. They could have cough, fever, weight loss, chills, night sweats. Chest x ray might be abnormal, and they might be contagious and could infect other people. Um, okay, so moving on to cystic fibrosis. Excuse me, my screen is freezing up a little bit. Okay, sorry. My scrolling got kind of weird, so I got kind of out of sync with my slides. I apologize. So you can review that little side-by-side chart right there. So you definitely need to know the difference between latent and active TB disease. Okay, moving on to cystic fibrosis. So you may or may not have heard of this. This is a genetic disorder and it affects the body's mucus producing glands. So this really affects the sweat glands quite a bit. And it causes a very thick, sticky mucus to build up in various organs, primarily the lungs, the pancreas, and the digestive system. We're really not going to talk much at all about cystic fibrosis effects on the pancreas and digestive system. We're going to focus on the respiratory effects. So, cystic fibrosis is what we would call an autosomal recessive genetic disorder. So, this means that both parents have to carry this altered CFTR gene, which we'll talk more about that gene and what it does in a minute. Um, this is more prevalent in Caucasian people of like European descent. So 1 in 25 Caucasians actually carry this altered gene. So if both parents are carriers, their children have a 1 in 4 chance of having cystic fibrosis. So the pathophysiology of cystic fibrosis, um, so basically, the CFTR protein is responsible for moving chloride, like sodium and water, into and out of out of the cell. So it really affects what mucus is composed of, which is actually a pretty big deal in the body, as you'll come to see as I talk about it. So basically there's a mutation where this protein gets misfolded. So we have a defective CFTR protein, and this bad CFTR channel doesn't allow chloride to move out of the cell like it should. So it just stays inside the cell when it really should be out and about helping hydrate the mucus. So without the chloride movement, the sodium and the water are staying in the cells, and we end up with this extremely thick, sticky mucus. So thick, sticky mucus is great for trapping bacteria and debris. Cilia are really no match for moving this mucus out. It is so thick and sticky. And people with cystic fibrosis have chronic infection and inflammation. You have these neutrophils and proteases that are being released that just really damage the airway walls. And this all leads to bronchiectasis, so collapse of the bronchi, and progressive airway destruction. So this is, primarily diagnosed in babies or very young children. Although recently I learned of someone who she was saying her daughter didn't get it diagnosed till she was a teen, which was like quite interesting to me. But the pulmonary effects of this are going to be a chronic cough. Starts off dry, but then later it's a productive cough with very thick mucus. Recurrent lung infections, because that thick, sticky mucus is like a perfect breeding ground for germs to grow. Weasels, crackles, rhonchi. They might have what's called digital clubbing. So that is when, if you looked at their fingers from the side, you would see their nail beds kind of like puffed up a little bit, because they are chronically hypoxic. So they have chronically low oxygen because their good gas exchange can't happen. Now, some of the GI symptoms, like one of the things with newborns is a meconium ileus, so they don't have their first poop like they should. And, this is gross, but they have something called steatorrhea, which is greasy, foul smelling stools, and that's due to malabsorption. Um, so there's just many symptoms, but the ones we're going to focus on today are all the respiratory symptoms. Um, how this is diagnosed is that, well, luckily now all newborns in the United States get screened for cystic fibrosis, and the sweat test is the gold standard. So, one of the things is that before newborns were screened in the US, sometimes parents would notice when they were, I guess, like kissing their baby, that their infant's skin was like extremely salty tasting. Um, and so that was kind of a clue, and they can do a sweat test and see what the composition of the sweat is. And if that salt and water content is at all affected, then that is very suspicious for cystic fibrosis. So sadly, treatment like this is lifespan has improved with cystic fibrosis, but it's improved to like 40s, 50s. So a lot of it is very like quality of life focused. Chest physiotherapy is done, basically where they kind of beat on the chest. I mean, they do it more elegantly than that, and they have special devices to move the mucus around and loosen it up so that it can actually be coughed out. And then they might be on bronchodilators, mucolytics, which would thin the secretions, antibiotic therapy. Not all the time, but you can imagine if you have constant mucus, it's safer to prescribe antibiotic therapy because they can progress to pneumonia very quickly. Supplemental oxygen for advanced lung disease. So people with cystic fibrosis will need that eventually, and a lung transplant. So a lung transplant is supportive. It's not curative, because it's not a problem with the lung itself. It's a problem with the CFTR gene. Um, okay, so let's move on to our last exemplar, which is acute respiratory distress syndrome. So this is acute non-cardiac pulmonary edema, meaning it's not caused by left-sided heart failure, and severe hypoxemia, so low oxygen in the blood that does not improve with oxygen alone. So a lot of things can trigger this: infection in the lung, sepsis, trauma, aspiration. Oh, I was going to say about pneumonia. One of the common causes for pneumonia can be somebody with impaired swallowability. They end up aspirating or choking on a piece of food, or a food particle makes its way down into the lungs and causes pneumonia, because on that food particle, a lot of pathogens that shouldn't be in the lung are there. So that can cause pneumonia. Okay, so back to acute respiratory distress syndrome. So this can happen to anyone with who had like an infection, sepsis, or trauma. And it's very serious. It can become fatal very easily. And it is one where those little tiny air sacs, the alveoli, and the blood vessels get injured and leaky after this initial insult to the lungs. So then what happens is fluid just starts leaking into the alveoli and the surfactant is gone. So the alveoli collapse. They don't have the surfactant to help hold the alveoli open anymore. So we can't exchange oxygen. Even if we supplement oxygen, we can't um, go in and hold the alveoli open ourselves. So people get what's called refractory hypoxemia. Um, there are, let's see, the big thing is alveolar capillary membrane damage, because remember, that's where that diffusion of oxygen and carbon dioxide takes place. Basically, what happens is endothelial injury leads to the capillaries becoming leaky, and protein-rich fluid floods alveoli. So type 1 pneumocytes die at that point. And type 1 pneumocytes form a primary lining of alveoli, and they're needed for gas exchange. And then we also have a type 2 pneumocyte that produces pulmonary surfactant that's needed for surface tension. So type 1 pneumocytes die, and type 2 pneumocytes decrease surfactant production. So this all leads to a lot of problems that can manifest in refractory hypoxemia. So low oxygen in the blood. There's different phases to ARDS. So we have phase 1, and that is, that's something bad happening, and that's called the exudative phase, and kind of like the reaction to that. And that typically lasts about 7 to 14 days. Or no, I'm sorry, 1 to 7 days. Then phase 2, which we call the proliferative phase, is about 7 to 14 days. Or day 7 to 14. And during that phase, we have these pneumocytes that come in. Well, let me back up a minute to phase 1. So, pneumocytes are the cells of the alveoli, and we have two types of them. So, type 1 pneumocytes are what form the primary lining of the alveoli, and they're very much needed for gas exchange. So that's type 1. Type 2 is pneumocytes that produce the pulmonary surfactant, and they are needed for surface tension. So, in phase 1, in the exudative phase of ARDS, non-cardiogenic pulmonary edema occurs, and then there's a loss of surfactant. So the surfactant isn't around to keep those like alveoli open. And in the absence of surfactant, the alveoli completely collapse. And this, it's kind of just this nasty cycle, and it leads to refractory hypoxemia. So let me see. Phase 2 is called the proliferative phase. So you can see that the type 2 pneumocytes start to proliferate to replace all the damaged cells that are lost and restore surfactant. Fibroblasts come in, they start laying down collagen. Some fluid reabsorbs, but the lung compliance is low because of fibrosis and persistent inflammation. Fibrosis is like that stiffening. So the body like tries to heal the lungs. New cells grow to replace the old ones and make more surfactant. Some of the fluid clears, but the lungs are still kind of hard to inflate. Now, during phase 3, we have what's called the fibrotic phase, and very few people progress to the fibrotic phase. There's a huge mortality risk to having ARDS. But, what happens is that you end up with very scarred, stiff lungs. And, if somebody makes it through this, they will need long-term oxygen for sure. How is this diagnosed? Well, they get a chest x-ray and a CT, and that's going to show bilateral alveolar infiltrates. It will also rule out anything else. Um, you know, Then there are ABGs. So those are arterial blood gases, and they can show low oxygen even with oxygen therapy. They might do an echocardiogram, because a big thing is with ARDS is fluid is overwhelming those alveoli, so diffusion can't take place. But there is, it could look a lot like fluid retention. So you need the echocardiogram to rule out left-sided heart failure. And then labs play a role as far as evaluating the cause. Um, so that can be pretty important as well. So here's just a little note on ABGs. So an ABG is an arterial blood gas. You may remember I said before an ABG, or I'm sorry, an acid-base balance. The body wants to stay between 7.35 to 7.45. So this is something we can monitor through arterial blood. With ARDS patients, they check their ABGs quite frequently. And it's interesting, in the early phases of ARDS, somebody will have respiratory alkalosis. So that pH would be over 7.45. And that is probably because somebody could still breathe just well enough. But in the later phases of our ARDS, the patient has respiratory acidosis because those little alveoli become very stiff and diffusion can't take place. So treatment of ARDS, prone positions. You see my little picture of the guy. They will need that because it helps them do what's called recruit the posterior lung field. So make the back of their lungs work a little harder is really good for them. This person has to be on a ventilator, and they need low tidal volume. And that just means basically small breaths that the very small breaths that the machine is delivering. And then also they need to be on what's called PEEP, positive end expiratory pressure. So that keeps the alveoli open longer. So those tiny breaths and then keeping the alveoli open longer are very key to treating this. Fluid restriction. So you don't want, this is not originating from the heart, but you don't want to throw fuel on the fire. You want to give as little fluids as is necessary, and perhaps watch somebody's oral intake. And then finally, we need to treat the underlying cause, because if it's sepsis, if it's pneumonia, if it's, something like that, then treating that will ultimately help the ARDS. All right, so that has been my very short overview of more alterations in the pulmonary system. Thank you for listening. I hope that you learned a lot. And as always, if you have any questions, please reach out. I encourage you to find, whatever information makes it make sense. But just let me know if I can be of any help to you. Goodbye.